American College Gastro American College of Gastroenterology, a guideline summary of Crohn's disease. Fecal calprotectin is a helpful test that should be considered to help differentiate the presence of inflammatory bowel disease from irritable bowel syndrome. In patients at particularly high risk for colorectal neoplasia, like personal history of dysplasia, primary sclerosing cholangitis, chromoendoscopy should be used during colonoscopy, as it may increase the diagnostic yield for detection of colorectal dysplasia, especially compared with the standard definition white light endoscopy. For patients undergoing surveillance colonoscopy, there is insufficient evidence to recommend universal chromoendoscopy for IBD colorectal neoplasia surveillance if the endoscopist has access to high definition white light endoscopy. Narrowband imaging shouldn't be used during colorectal neoplasia surveillance examinations for Crohn's disease. Non-steroidal anti-inflammatory drugs may exacerbate disease activity and should be avoided when possible in patients with Crohn's disease. Cigarette smoking exacerbates disease activity and accelerates disease recurrence and should be avoided. Use of antibiotics shouldn't be restricted in Crohn's disease patients in order to prevent disease flares. Perceived stress, depression, and anxiety, which are common in IBD, are factors that lead to decreased health-related quality of life in patients with Crohn's disease and lead to lower adherence to provider recommendations. Assessment and management of stress, depression, and anxiety should be included as part of the comprehensive care of the Crohn's disease patient. Sulfasalazine. Sulfasalazine is effective for treating symptoms of chronic Crohn's disease that is mild to moderately active and can be used as treatment for this patient population. Controlled ileal release budesonide at a dose of 9 mg once daily is effective and should be used for induction of symptomatic remission for patients with mild to moderate LUC Crohn's disease. Metronidazole is not more effective than placebo as therapy for luminant inflammatory Crohn's disease and shouldn't be used as primary therapy. For patients with low risk of progression, treatment of active symptoms with antidiarrheal, other non-specific medications, and dietary manipulation along with careful observation for inadequate symptom relief, worsening inflammation, or disease progression is acceptable. Oral corticosteroids are effective and can be employed for short-term use in alleviating signs and symptoms of moderately to severely active Crohn's disease. Thiopurine, like azathioprine or 6-mercaptopurine, are effective and should be considered for use for steroid sparing in Crohn's disease. Azathioprine and 6-mercaptopurine are effective therapies and should be considered for treatment of patients with Crohn's disease for maintenance of remission. Thiopurine methyltransferase testing should be considered before initial use of azathioprine or 6-mercaptopurine to treat patients with Crohn's disease. Methotrexate. Methotrexate up to 25 mg once weekly intramuscular or subcutaneously is effective and should be considered for use in alleviating signs and symptoms in patients with steroid-dependent Crohn's disease and for maintaining remission. Anti-tumor necrotic factors agents like should be used to treat Crohn's disease that is resistant to treatment with corticosteroids. Anti-tumor necrotic factors agents should be given for Crohn's disease refractory to thiopurine or methotrexate. Combination therapy of infliximab with immunomodulators like thiopurine is more effective than treatment with either immunomodulator alone or infliximab alone in patients who are naive to those agents. For patients with moderately to severely active Crohn's disease and objective evidence of active disease, anti-integrin therapy with vedolizumab, with or without an immunomodulators, is more effective than placebo and should be considered for use in induction of symptomatic remission in patients with Crohn's disease. Natalizumab is more effective than placebo and should be considered for use in induction of symptomatic response and remission in patients with active Crohn's disease. Natalizumab should be used for maintenance of natalizumab-induced remission of Crohn's disease only if serum antibody to John Cunningham virus is negative. Testing for anti-John Cunningham virus antibody should be repeated every 6 months and the treatment stopped if the result is positive. Ustekinumab. Ustekinumab should be given for moderate to severe Crohn's disease patients who failed previous treatment with corticosteroids, thiopurine, methotrexate, or anti-tumor necrotic factors inhibitors, or who have had no prior exposure to anti-tumor necrotic factor inhibitors. Intravenous corticosteroids should be used to treat severe or fulminant Crohn's disease. Anti-tumor necrotic factor agents like infliximab, adalimumab, certolizumab, Vigol can be considered to treat severely active Crohn's disease. Infliximab may be administered to treat fulminant Crohn's disease. Infliximab is effective and should be considered in treating perianal fistula in Crohn's disease. Infliximab may be effective and should be considered in treating enterocutaneous and rectovaginal fistulas in Crohn's disease. Adalimumab and certolizumab Vigol may be effective and should be considered in treating perianal fistulas in Crohn's disease. Thiopurines like azathioprine and 6-mercaptopurine may be effective and should be considered in treating fistulizing Crohn's disease. The addition of antibiotics to infliximab is more effective than infliximab alone and should be considered in treating perianal fistulas. Drainage of abscess surgically or percutaneously should be undertaken before treatment of fistulizing Crohn's disease with anti-tumor necrotic factor agents. Once remission is induced with corticosteroids, thiopurine or methotrexate should be considered. Anti-tumor necrotic factor therapy, especially infliximab and adalimumab and certolizumab Vigol, should be used to maintain remission of anti-tumor necrotic factor-induced remission. Anti-tumor necrotic factor monotherapy is effective at maintaining anti-tumor necrotic factor-induced remission, but because of the potential for immunogenicity and loss of response, combination with azathioprine, 6-mercaptopurine, and methotrexate should be considered. Imidazole, antibiotics, metronidazole, and ornidazole at doses between 1 and 2 grams per day can be used after small intestinal resection in Crohn's disease patients to prevent recurrence. In high-risk patients, Anti-tumor necrotic factor agents should be started within 4 weeks of surgery in order to prevent post-operative Crohn's disease recurrence. An intra-abdominal abscess should be treated with antibiotic and a drainage procedure, either radiographically or surgically.